Welcome to MedSimu Surgery Podcast.
Great to be here.
Today, we're diving deep into something really fundamental for surgeons, especially if you're prepping for exams like the MRCS. We're talking about the initial management of burn injuries, getting those first steps right.
Absolutely crucial. We'll be pulling together the key information, sort of a framework for approaching these patients right from the moment they arrive.
Sounds good. So what ground are we covering?
We'll look at that initial assessment, the underlying pathophysiology, what's actually happening in the body, then diagnosis, and critically, those immediate management strategies. Think fluids, wound care, the essentials.
Perfect. Let's jump straight in then. Initial assessment. Where do we start?
First thing to remember, a significant burn isn't just skin deep, it's a systemic hit.
Right, it affects everything.
Exactly. Airway, breathing, circulation, your standard trauma priorities, and then obviously dealing with the burn itself.
And a big part of that initial assessment is figuring out how much of the body is burned.
Precisely. The total body surface area, or TBSA, it guides so much of the early management.
How do we estimate that quickly? I remember the rule of nines.
That's the one. For adults, it's a really practical tool. You divide the body into areas that are roughly 9% or multiples of 9.
So like an entire arm is 9%, a whole leg is 18%.
You got it. The head and neck together are 9%, front of the trunk 18%, back of the trunk 18%, makes 11 areas of 9%.
And the last 1%.
That's allocated to the perineum. Just important to note, it can sometimes underestimate TBSA in obese patients. Something to keep in mind.
Good point. And these injuries are common, aren't they?
Sadly, yes. In the UK, we're talking around 250,000 burn injuries each year.
Wow.
And about 13,000 of those need hospital admission.
And needing fluids.
Roughly 10% of those admitted will need formal fluid resuscitation because the burn is significant enough.
And tragically, people still die from burns.
Yes. Despite all our advances, around 300 deaths annually in the UK, it really highlights why getting that initial management right is so vital.
Absolutely. And what causes these burns typically?
It varies. Thermal burns are probably the most frequent. You see scalds a lot, especially in kids.
Right.
And flame or fire injuries are more common in adults.
But there are others too.
Oh, yes. Chemical burns, electrical injuries, which can be deceptive. The skin injury might look small, but there can be deep damage.
Following the current's path.
Exactly. And then radiation burns, from sunburn right through to more significant exposures.
Okay, so we've got the assessment basics and the causes. What's actually happening physiologically when someone sustains a major burn?
It triggers this massive inflammatory cascade. The body just floods with mediators, histamine, prostaglandins, bradykinins, leukotrienes, serotonin, the whole lot.
And what do?
They cause widespread vasodilation, blood vessels opening up, and increased capillary permeability.
So the vessels get leaky.
Precisely. Fluid pours out of the bloodstream into the surrounding tissues. That causes edema, swelling, and critically, it reduces the amount of fluid circulating.
Leading to poor oxygen delivery.
Exactly. It impairs tissue perfusion. It's like all the pipes suddenly springing leaks, pressure drops, flow is compromised.
And locally, at the burn site itself.
We often use the Jackson model to think about that. Imagine 3 zones.
Okay.
Innermost is the zone of coagulative necrosis. That tissue is dead, directly killed by the heat.
So saving that now.
Then surrounding that is the zone of stasis. Here, the microcirculation is damaged, blood flow is sluggish. This tissue is injured, but potentially salvageable.
So resuscitation is key for this zone.
Absolutely. Good fluid management can potentially save some of this tissue. And the outermost zone is the zone of hyperemia.
That's just red and inflamed.
Essentially, yes. Lots of vasodilation due to those inflammatory mediators. This contributes to the swelling, too. And if the burn is big enough, say over 20% TBSA, this local reaction becomes systemic.
Right, the whole body gets involved.
Yeah.
And there's a longer-term metabolic thing, too, isn't there?
Yes, the hypometabolic response. The stress of the injury triggers a massive release of stress hormones, catecholamines, glucagon, cortisol.
Putting the body into overdrive.
Exactly. And at the same time, the body becomes less responsive to anabolic hormones like insulin and growth hormone. This state can last a long time and leads to increased energy needs, muscle breakdown.
Makes sense. So how does all this manifest when the patient arrives? What are the key signs we look for?
Well, the most immediate concern is often hypovolemia from that fluid loss. If it's not treated fast, it can lead to shock, organ damage like acute kidney injury.
Okay.
The heart struggles too. Cardiac output can drop because there's less fluid returning to the heart, decreased preload. Plus, there might be some direct myocardial depression and increased afterload as the body tries to compensate.
What about the lungs?
You can see ARDS, acute respiratory distress syndrome, especially with large burns or inhalation injury. And immunosuppression is a huge issue.
Making infection a major risk.
A massive risk. These patients are incredibly vulnerable. Then you said the signs of that hypermetabolic state. Tachycardia, maybe a raised temperature, muscle wasting over time.
And gut problems.
Yes, gut dysfunction, like an ileus, is common too.
It really is a whole body assault. So, patient arrives, potentially with all this going on. How do we approach diagnosis and initial investigations?
Stick to the script. ATLS principles. Airway first, always.
Looking for signs of inhalation injury.
Absolutely. History of being in a closed space fire, facial burns, soot around the nose or mouth, singed nasal hairs, hoarse voice. Any of those should make you very suspicious.
And if you are suspicious?
Low threshold for early intubation. That airway swelling can be insidious and peaks around 12 to 36 hours later. You don't want to be caught out.
Got it. Secure the airway early.
And high flow oxygen right away. Then breathing, circulation, IV access, large bore cannulas, ideally through unburnt skin if possible.
And assessment means getting a proper look.
Yes. You have to remove all clothing and jewelry. You can't assess the burn properly otherwise. It might feel counterintuitive with heat loss, but you need to see the full extent. Keep them warm afterwards, of course.
Standard trauma workup, too.
Definitely. Trauma series, x-rays, chest, pelvis, lateral C-spine, just like any major trauma patient. Burns often happen alongside other injuries.
And specific things for certain burns.
Yes, for electrical burns, or if there's any history suggesting loss of consciousness or an abnormal ECG on arrival, get them on continuous cardiac monitoring. Risk of arrhythmias is real.
Okay, primary survey done, immediate threats managed. Then we focus more on the burn wound itself.
Exactly. Secondary survey time. Get a detailed history. Mechanism of injury, duration of contact, what first aid was given, did they run it under cool water?
And assessing the burn depth becomes crucial now.
Absolutely critical. It dictates fluid management, surgical need, everything. It's not just about the percentage TBSA.
Is it easy to judge depth clinically?
It can be tricky, especially early on. Experience helps. But there are tools now, too, like laser Doppler imaging, which NICE has approved. It gives a more objective measure of blood flow in the wound bed.
How do we categorize depth clinically, though?
Broadly, superficial or deep. Superficial burns involve the epidermis, maybe the epidermis.
Like sunburn.
Epidermal burns are like sunburn, yeah. Red, painful, no blisters. They heal well. Superficial dermal burns go a bit deeper, they blister, they're very painful, but they still blanch. Capillary refill is normal. They usually heal without scarring, mostly by reepithelialization.
Okay. And deep burns?
They involve deeper layers of the dermis or even full thickness down to fat or muscle. These almost always need surgery.
How do they look?
Deep dermal burns might be red or blotchy, maybe fewer blisters. Capillary refill is often sluggish or absent. Full thickness burns look different, often white, waxy, leathery, or charred. No blisters, no capillary refill, and often less painful because the nerve endings are destroyed.
Right. The lack of pain can be misleading.
Very much so.
Okay. Assessment, complete extent, and depth estimated.
Right.
Let's talk management. Non-pharmacological first. Fluids seem key.
Top of the list for significant burns. We're talking deep, partial, or full thickness burns covering more than, say, 20% TBSA in adults or maybe 10-15% in children.
And the formula? Parkland or Luden?
The ATLS guidelines generally recommend using a formula like the modified Parkland. For adults, it's typically 2 milliliter of lactated Ringer solution per kilogram of body weight per percentage TBSA burned.
So 2 times weight in kilogram times percent TBSA.
Exactly. That gives you the total volume estimated for the first 24 hours after the injury occurred.
Not from when they arrive.
Crucially, no, from the time of the burn. And the rate is important, too.
How do we give it?
You aim to give the first half of that calculated volume over the first 8 hours post-injury, and the remaining half over the next 16 hours.
Are there different volumes for kids or specific injuries?
Yes, for children, we often use 3 milliliter percent TBSA, and for electrical burns, it's higher still, often 4 milliliter percent TBSA, because of that potential for deeper hidden muscle damage.
But it's not just plug in the numbers and walk away, right?
Absolutely not. The formula is just a starting point, an estimate. You must titrate the fluid rate based on the patient's response.
How do we monitor that?
Urine output is the key guide in most cases. Aim for about 0.5 milliliters per kilogram per hour in adults.
And kids?
Aim for 1 milliliter per kilogram per hour in children under 30 kilograms. You adjust the infusion rate up or down to hit that target. Fluid boluses should really be reserved for hemodynamic instability.
Okay, fluids covered. What else non-pharmacologically? Temperature.
Yes, very important. If they present within, say, 3 hours of the burn, cooling the wound with cool running water, not ice cold, think 8 to 25 degrees Celsius for about 20 minutes is beneficial.
Reduces tissue damage.
Helps limit the burn depth and inflammation. But don't make the patient hypothermic. After that initial cooling, focus on keeping them warm. Remember that hypermetabolic state? We need to control the room temperature, maybe around 33 degrees Celsius, to minimize heat loss and metabolic stress.
Nutrition.
Early feeding is vital for major burns. Get a nasogastric tube in if they can't eat, and start enteral feeding soon. It helps maintain gut function and provides the huge amount of calories they need.
And initial wound care, just cover it up.
Gently clean the wound, maybe with saline or very dilute, like more 0.1% chlorhexidine. Then apply simple, non-adherent dressing.
What about cling film? I've seen that used.
It can be a good temporary dressing, especially during transfer. It's clean, non-adherent, reduces evaporative losses, and allows assessment. But critically, don't wrap it circumferentially or too tightly.
Risk of constriction if swelling occurs.
Exactly. And don't forget early physiotherapy and occupational therapy involvement, essential for function long-term.
What about chemical burns specifically?
Priority number 1 is remove contaminated clothing safely, then copious irrigation with water. Lots and lots of water to dilute and wash off the chemical.
For how long?
Often for extended periods, 30 minutes or more. Specific advice might be needed depending on the chemical check manufacturer data or toxicology resources. Hydrofluoric acid is a particularly nasty one, needing specific treatment with calcium gluconate.
Okay. And when do these patients need transferring to a specialist burns unit?
There are clear referral criteria, generally adults with over 10% TBSA, kids with over 5%. Extremes of age.
Any specific burn types or locations?
Yes. Full thickness burns over 5% TBSA. Burns to special areas: face, hands, feet, perineum, major joints. Circumferential burns of limbs or the chest. All electrical and significant chemical burns.
Associated injuries.
Any burn with associated inhalation injury needs specialist care. Burns in patients with significant comorbidities or burns associated with other major trauma. Basically, anything complex or potentially life or limb-threatening.
That's a helpful list. Okay, moving on to pharmacology. What drugs are key early on?
Pain relief is paramount. Intravenous opioids titrated carefully to effect. That's the main pharmacological focus initially.
What about those other things mentioned for the hypermetabolic state?
Things like insulin therapy for hyperglycemia, maybe anabolic steroids or beta blockers to blunt the stress response. Those are typically considered later in the management of severe burns, not usually in the first few hours.
And antibiotics. Should we give them prophylactically?
That's a really crucial point. No, routine prophylactic antibiotics are not recommended.
Why not? Seems intuitive with the infection risk.
Because it doesn't prevent infection effectively and massively increases the risk of selecting for resistant organisms, which makes treating actual infections much harder later on. Antibiotics are for treating confirmed infections, not for prevention in burns.
Got it. No routine prophylactic antibiotics. So what about surgery?
Surgery is a cornerstone of managing deeper burns. Early excision is key.
How early?
Ideally within the first 72 hours for deep dermal and full-thickness burns. Taking off that dead tissue early has huge benefits.
Such as?
Faster healing, less blood loss overall compared to delayed surgery, shorter hospital stays, better cosmetic and functional outcomes, less scarring, and it's even linked to improved survival in major burns.
And what about those tight circumferential burns?
If a circumferential full-thickness burn on a limb is compromising blood flow distally, or one on the chest is restricting breathing, then an emergency escharotomy is needed.
Which is?
It's a surgical incision through the full thickness of the eschar, the burnt tissue, down to the subcutaneous fat. It releases the constriction, usually done with diathermy to control bleeding.
And once the dead tissue is removed, how do we close the wound?
The gold standard is usually a split-thickness skin autograft, taking healthy skin from an unburned area of the patient, the donor site, and putting it onto the excised burn wound.
What if the burn is too large, not enough donor site?
That's a major challenge. We might use temporary coverings like allograft skin from a deceased donor or synthetic skin substitutes like Integra, which acts as a dermal scaffold. These can buy time or help prepare the wound bed for later autografting.
So that covers the acute phase. What about the longer-term picture?
Burns leave lasting scars, both physical and psychological. It's a long road for many patients.
What are the main physical challenges?
Wound contracture is a huge problem. As the scar tissue matures, it tightens, which can severely limit movement, especially around joints.
How do you manage that?
Early and ongoing physiotherapy, pressure garments, and sometimes splinting are absolutely vital to minimize contractures. Further surgery might be needed later, too.
And that hypermetabolic state, does it resolve quickly?
In very large burns, say over 40% TBSA, it can actually persist for up to 2 years after the injury.
2 years? Wow.
Yes, meaning ongoing high nutritional needs and risk of muscle loss. So long-term outpatient follow-up is essential for scar management, rehabilitation, checking nutritional status, and crucially, providing psychological support. The impact is profound.
It certainly sounds like it. Well, that was a really thorough run-through of managing burn injuries initially. We've hit on that critical first assessment, understanding the why with the pathophysiology, the key steps in resuscitation, like fluids, using the formulas, but titrating carefully.
And the importance of early excision and knowing when to refer.
Absolutely. It really underscores how a systematic approach in those first hours and days makes such a difference to outcomes.
It truly does. Having that clear framework is fundamental for anyone dealing with these complex injuries.
We really hope this deep dive has given you, our listeners, some valuable takeaways, whether for your exams or your day-to-day practice.
Hopefully reinforcing some key principles.
Definitely. Join us next time on MedSimu Surgery Podcast for another in-depth discussion on a key surgical topic.